So I think actually now I want to go back. Yeah, that's it. Okay, so I'm talking to you, and you're very close to the birthplace of Homo sapiens. And my talk is going to start not quite as far back as that, but it's going to. So I started in 1973, and so that was a completely different era in oral and maxillofacial surgery and many other medical specialties. And what's amazing is when you look now. This is the desert, and this is Dubai, and you see, you know, how the ascent of man has been able to transform the desert into a thriving city, which lots of people like to visit. I'll just tell you briefly what I'd like to talk about, and that's, first of all, I'm afraid Imad wanted me to talk for the whole 2 hours. Which I think is a bit too much. I think the talk will probably take about an hour and 10 minutes, and that should leave enough time for talking afterwards. Are you okay with that, Salah?
Yes.
Yeah, okay. You poor soul, you're having to stay here listening to something which is nothing to do with cardiology. But anyway, what I would like to say is you're recording this, and if we could have a recording of it for the Saving Faces later on, that would be good. Okay. So the next thing I want to talk about is partnership with patients, then about the National Research Centre and about evaluation, prevention, innovation, clinical and translational research, how you can join. And I want to give a plug to Alan Rickman, who's died, unfortunately, who played Snape. I hope all of you see Harry Potter. Do people see Harry Potter films?
I personally haven't, but I heard a lot about it.
Yes, okay. Well, yeah, so he's Snape, and I'll talk about him at the end. Anyway, let's start. So this is about revolutions in facial surgery, and it really is starting long before I started in 1973, but I was there. So what happened? So I asked one of my colleagues when I was president of the president of the British Association of Oral and Maxillofacial Surgeons, I asked him to do the Norman Rowe lecture, and he chose, and I wanted to do about the history of oral maxillofacial surgery, and he focused on Lister and anesthesia. He didn't focus on changes in the you know, in the armamentarium that we have. So when you look back at it, and when you think back to the start of Homo sapiens, antisepsis was in the 19th century, so it wasn't that long ago. It was coming up to two centuries, but that's all. Semmelweis at the end of it was revolutionizing hand washing in gynecology and obstetrics. And interestingly, he was thrown out of the medical school, I think, because they hated the fact that he wanted them to wash their hands. Antibiotics have only been with us since really after the Second World War. I mean, it's hard to believe. They've transformed our lives. Things that killed us before don't kill us anymore. And we use it now for prophylaxis, of course. And there's a whole argument about the resistance being built up by using it too much. We've now got antiviral, antifungal, antiparasitic, and we've also got autoclaving and much more sophisticated things than that. Anesthesia really goes back only about 2 centuries, but of course it's that's the first general anesthetic with ether in America, Massachusetts General. Before that, people were using carbon dioxide, they were using nitrous oxide, they were using cocaine, they were using all sorts of things, so all sorts of stuff. But in anesthesia, I've seen a revolution in my lifetime. And I have to say that I've been present at the death, at the avoidable death of 2 patients, one of whom was about to have a hernia operation, and I was the house officer, and we were waiting for the patient to come into theatre, and he didn't come into theatre. It was 4 hernias were going to be operated on that morning, and so he should have come through quickly. And he'd been esophageally intubated, and of course there was no carbon dioxide monitoring, no pulse oximeter. Problem, the patient's heart stopped, and he rang the bell for the with the patient still esophageally intubated. And then there was a young boy, age 12, who had ankylosis of his jaw joints from an earlier fall, and there was no fiber optic intubation then. And a young consultant kept trying to intubate it without success. And in the end, finally called us into, as we were waiting patiently, to do a tracheostomy. But the point was that we didn't have the tracheostomy kit set up. We didn't have anything set up, and the boy died. So I've been present, and these things have stayed in my mind. So pulse oximeters, carbon dioxide monitoring, fantastic. For fiber optic intubation has changed the world for me. Intravascular monitoring, anesthetic agents, intravascular agents, yeah, safer intubation, DVT prophylaxis, gel mats preventing bed sores. When I started as a consultant, lots of my patients were getting bed sores. So there have been massive advances in that. Blood products, clotting factors, separated out, albumin, erythropoietin, human fibrin glue. All things that have helped us in our thing. Interventional radiology. This is a little girl with a blood vessel tumor, benign blood vessel tumor, or I probably shouldn't call it a tumor, but it is a swelling, wrapped around her facial nerve, and I was able to they couldn't do interventional radiology on her, but I was able to identify the vessels, the major vessels, and sling those so that I had a relatively avascular field when I was taking out the lesion, and there she is later on. Hemostasis, bipolar diathermy, now high frequency ultrasound, human fibrin glue, oxidized cellulose, so many things that before we even get on to the surgical advances. So here's a carotid body tumor, and I don't damage the carotid at all, using bipolar to get rid of this vascular tumor that nestles between the internal and external carotid. And you can see the slings are around the vessels just in case there's a problem. But the real advance for me for these type of cases is the ultrasound, high frequency ultrasound, which in even the most difficult cases. Diagnosis, radiology and interventional radiology, CT scans, ultrasound, down to 3D printing, genetics. There have been so many advances that have aided us. But in surgery, when I first started, plates, we didn't use plates at all, because the plates were massive, great blocks of stainless steel or something like that, and you couldn't bend them into any shape at all. And they were used for orthopedics, but we never had mini plates when I started. And so we were using, as you'll see in a moment, wires around the teeth, and we weren't plating bone directly. Laser, ultrasound, disposable equipment, microscopes and loops. Microscope has revolutionized the reconstruction of head and neck cancer and other reconstructions. And then retractors, implants, keyhole, endoscopic things, and loop robots all now have a role to play. So this is a view of somebody in the old days with a broken jaw, and you can see all these arch bars wrapped around the teeth with stainless steel wire, and that's now very old. It's not used much at all. Here's a boy who was shot at point blank range by his cousin with a shotgun, and he's on the operating table. And so with an endoscope, I was able, without having to open up the skull or do anything like that, or bring in my neurosurgeon to take out quite a lot of the pellets that were right at the back of his nose, but hadn't gone through, fortunately hadn't gone through the cribriform plate or my brain, the bone, the solid bone at the back. I'll remember it later on in the talk. Anyway, so I was able to remove the pellets because of endoscopy, and there he is afterwards. Unfortunately, the optic nerve had been damaged permanently, and my raising the pellets didn't. That was why I did that operation immediately, was to try and get the pellets off the optic nerve, but I didn't succeed because it was already damaged. Transplantation. If we talk about transplantation, we always, in the past, we used skin grafts, grafts from other people, xenografts from animals and alloplastic materials. And so that grafts were the first kind of thing used. But if we go back to India in before Christ, I think about 3 centuries before Christ, on the banks of the river at Benares or Varanasi, there was the school of Shashruta, and you'll see in a moment I'll show using a Shashruta flap to 3 almost, well no, 2 millennia apart. Okay, metal implants in Europe we used to reconstruct noses. In 1900, Tanzini in Italy described what I think is the first myocutaneous axial flap, which was the latissimus dorsi flap, and he described it in relation to the artery and vein supplying that muscle and supplying the overlying skin. So there were, the Shashruta flap was in fact an axial flap, as I'll mention in a moment, but it wasn't described as such. It was described as probably as a random pattern flap. Gillies and Mackinder made some advances in the Second World War, but really the major advances were made in axial flaps in the 1970s, a long gap between 1900 and the 1970s because Tanzini wasn't believed in what he'd found, and revascularized microvascular free flaps at the same time in the 1970s. So this is a young man who's had his nose bitten off, and you can see the cartilage sticking out from side to side. And you can see, so this is one of the Saving Faces Arts exhibition paintings. You'll see these as we go through. And this is at the point, so we've turned around the forehead flap, which is based on the supratrochlear and supraorbital arteries and vessels. And we've turned it around and used it to cover the nose to begin with. And this is the time when we're going to divide the flap, when we think it is vascularized from below as well as from above. So it's no longer surviving on the supraorbital and supratrochlear vessels. And you can see the pink blush around the nasal tip, as well as the pink blush at the back. So it shows that we can divide that so that we end up with a reasonable result. But that's a flap from getting on for 2.5 millennia ago. So this is microscopic plumbing. That's all it is. I don't think I can use, oh yeah, I can use my arrow. There's the artery up at the top, and there are 2 veins that have been isolated and used in that. And of course, that's led to the face transplant, which is the most radical of the treatments that we use at the moment. In fact, very few people use it, and even some of its advocates have stopped using it. So this is a guy who shot his face off. You can see the hole right at the bottom here, around here, where his mouth was, and it went under here. So he used a shotgun, and classically what happens is when you hold the shotgun up under, you know, it's a long way down to the trigger, and so your head goes back, and all you do is you blow off your the front of your jaw, your lower lip, the upper lip, the nose, and you may chop off your frontal lobes of the brain as well. And so that's him, and that's how he looks afterwards. not a result that I think I would be proud of. But I think for burns, it's really useful. But I think for when you're dealing with the underlying bones, you can get a better result with microvascular flaps. So now I want to move on to the second thing, which is, so these are the advances that I've been fortunate to live with. I would never have wanted to be a head and neck surgeon in 1973 when I was working on the head and neck unit at the Westminster Hospital. Because the patients had paper bags over their head, the reconstruction was so rudimentary. So I would never have chosen it. But during the course of my early training, the revolution occurred, and I've lived, fortunately, with that revolution, with the benefits of it. But what's important throughout this talk is that you never, and this is a problem for new recruits into the specialty, they have not lived through these revolutions. And so those are forgotten. And when they run into trouble with the modern techniques, they don't know about the backup techniques that they could have used. And at some stage, I hope to remember to mention Klaus Wolf and Frank Holzer from Germany, so at the moment with head and neck cancer, we're curing so many people with our surgery, and they're getting recurrences later on, or getting new tumors later on. So some patients I've operated on over 20 years, maybe 3 or 4 times, with oral squamous cell carcinoma, different oral squamous cell carcinomas. And so we run out of vessels in the neck, and so we're looking for vessels that we can use from elsewhere in the body. And what Frank and Klaus have done is that they have amalgamated the old style reconstruction from the First World War and Second World War of Gillies and Mackindo, which was bipedicle flaps, and use those to travel up and then convert them into microvascular flaps right up at in the neck and face. So I'm glad I've got that out of the way, because I haven't made a slide for them. So I think they deserve great praise, because they've amalgamated old with the new, and they've kept the old alive. And I think the old being alive is very, very important. So let's just think about the patient again. First, do no harm. Do not overtreat, or conversely not treat. Treat the patient, not the disease, and treat the family. Don't forget to treat the family. Know when you don't know and refer on. Treat your patients with respect and warmth. That's very important. And prevention is better than cure. So we'll look at that in a moment. So patients and surgeons, are we enemies or friends? So what we have here is Iain Hutchison with Professor Simon Holmes. And we're doing this this was many, many years ago, about 10 years ago, I think, something like that. And it was before my valedictory lecture. And you can see I've covered myself to show that I'm frightened of the patient. The patient is carrying disease to me. In the plague in London, all the doctors and monks left the city when the plague was there, and the poor kind of, not midwives, but nurses or whatever you might like to call them, looked after the ill, because everybody was frightened of catching the plague. So in this recent pandemic, it's very interesting that it's come back to that. Are the patients dangerous to us? So in our Central London Teaching Hospital, which doesn't have very many violent attacks on its grounds, we now have men outside, not with beautiful maroon jackets and tie and things, with a nice uniform, saying, where would you like to go to? Oh, you want to go to Henry Butlin Ward? Oh, right, okay. There you go there, that way. We now have 2 people with vests on, armored vests on, and they don't know where anything is in the hospital. So they're not here to help the patient. They're here to protect somebody or other. I don't know who. Anyway, that's what it was prompted by, but of course it's pertinent now. But don't forget, we're all patients waiting to happen. How many people here just think about it, have had surgery. I bet you that because you're a young population, you're probably only about 25% have had operations already. But, you know, we're all patients waiting to happen. So let's not forget that. So patients come in all shapes and sizes, and they behave differently, and they need to be treated differently. It's like that thing by the guy from Tufts University, the thing that he said to augment the Hippocratic Oath. It's to treat the patient, not the disease. So it depends on all these things. And so, but in general, they're all anxious. They all are frail when they're ill. They fear the disease and they fear the treatment when it's the facial surgery. So, and then they may have anger as well. So this is a young girl who was about 12, I think, when this was taken, who has ankylosis of the jaw, and her jaw hasn't grown. And you can see that she's wearing a school uniform, and she's not. Her parents are not ignorant. The problem is they've gone to many surgeons, and they've always got a different answer, and so they can't make up their mind what to do. You can hear me all, can you? I hope. Yeah, good. Okay. And a teenager. This is a teenager who's been cured. So the radiotherapist says, "I've cured him," and he was cured with radiotherapy for a retinoblastoma. But what's happened is that his face hasn't grown on the left-hand side, and so he's got a sunken eye, and the eye is smaller. His nose is over to the left, and he's going to go to university, and he wants to have his face improved. So it's not surprising that he wants to have that changed. Anyway, and then adults. This man had half of his nose bitten off when he was about 18, and his daughter, he came to have surgery. They actually took the nose off the ground and stitched it on, but it was never going to succeed. And he didn't bother having any more surgery until he was in his early 30s. And his daughter, who was 5, said, "I don't want to walk to school with you, Daddy. Will you walk behind me a long way so that people don't look at you and associate you with me?" So that's a different attitude to what middle age. This is a man who didn't have a satisfactory reconstruction of his lower jaw after it was removed. And this is a man who's had skin cancer and has had things done to that. They have, while they would like to have something more done, they don't want to have a major surgery. So you can see he's had surgery to his upper lip has been completely removed. His nose has been completely removed, and we could have put in a microvascular free flap, but he didn't want to do that. So he's got a lesser thing. So what does the patient expect from the surgeon? Well, the things in black are really, they want us to put a metaphorical arm around them and say, "I'm going to cure you." And they want us to be confident, and they assume we've got knowledge and experience. Not always the case, and skill. But it would be nice if we listened to them, the patient. They'd like that, and then engaged in a dialogue with them about what they want and what they don't want, and have a bit of understanding about how important, why they want to delay their cancer treatment, because their budgergar, so they've got to find a home for their budgergar while they're in hospital. You know what a budgergar is? Bird.
Yeah, I thought it was a dog for a minute, but yeah.
A bird, yes. Okay. Yeah. Okay. So it could have been a dog. Yeah. They think we know best treatment from research evidence. Well, we don't. They assume we only treat when we're competent and not drunk or something. And the patient is not training material. We design the treatment plan based on them. Well, not necessarily. We do it on protocols. We follow their progress, and if things go wrong, we take responsibility. So when we're dealing with a face, I think it's very important to, particularly when we're going to talk about changing people's faces, we need to beware, because surgery is irreversible and surgery causes harm. So we should think about the risk, and in all cases, we should think about the risk versus benefit, but it's especially important if we're changing people's appearance. They assume that we can have the same outcome with each operation, but of course, we don't do a production line thing. We treat patients individually, I hope, and some have more difficult problems than others. That we must imbue other staff with confidence. When things are going wrong in the theatre, it's not enough for me to put my head and my hands and say, I want my mummy, I want my mummy, where's my mummy? You know, I have to be calm, I have to, you know, deal with the problem. Preoperative preparation is vital, but even more important is post-operative management, okay? Because complications can occur at any stage afterwards. But a lot of surgeons don't you know, they do the operation and that's it, they're happy. So there is a mythology of the surgeon, and I've got it in red at the top: thoughtless, insensitive, arrogant, low emotional IQ. That's us, okay? You cardiologists are much better off. You have, they think we love operating and not interested in outcomes or patients. We're bombastic and we're certainly not intellectual. Are we a different species? Automatons, robots? Safe? Are we safe? Are we risk averse? But surgeons are human beings, and we suffer with anxiety and uncertainty and frailty and illness and failure. Now, failure is really, 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 really important, because you learn more from failure than you do from success. There was a film that was on YouTube, was about an operation that I did on a young woman from Zimbabwe who had a sarcoma, which had recurred after treatment at Groote Schuur Hospital in South Africa. And she had, her eyes were out on the side because the tumor had grown through the middle of her frontal fossa and down, and destroyed all the bone and the nose and everything. So effectively, once I'd taken out the tumor, her meninges in the frontal lobe were in air contact with her tongue. There was nothing between. And the flap failed. It failed on the table. I resuscitated it, but it failed ultimately. And the problem was that I had to solve that problem. And so I'm proudest of that film because it shows failure. And it wasn't my surgical technique. It was something wrong with the woman after she'd had a chemotherapy and so on. And I had very limited options for reconstruction. And I had to make sure that she if I hadn't done a due diligence of, working out why it had failed on a physiological basis, she would have died. So, it was a very important thing. But I think the most important thing about surgeons is, let me just say, yeah, I'll come back to it, is having courage, okay? It's a harmful act, it's irreversible. And so it's very, very important that the doctor and the patient or the family agree on treatment. We get failures and complications even with the best surgery and the best surgeons. Therefore, a surgeon must be decisive, confident, able to evaluate the risk-benefit ratio satisfactorily, and resourceful, and know their history of surgery so they can use previous simpler reconstructions and simpler projects when necessary, when things go wrong. And I put down courageous again. The problem is, when you look at this, decisive, confidence, the problem is that is kind of almost on arrogance. And so I say to people, I'm the most humble surgeon you'll ever meet, because I'm only 99.99% sure that I'm right. And I don't think of myself as a god. I think of myself as a demigod, so I'm only half a god. So I'd say that's humble for a surgeon. And we have to have confidence in what we're doing. We don't want to cause harm to people. So we think we're choosing the best treatment, and that is the opposite of what we want from somebody who's doing clinical research. We want them to have an open mind to say, well, I think my treatment works better, but the other surgeon thinks their treatment works better. So let's look at them and compare them all in a prospective randomized study. Is everybody still awake, or are you getting bored with this thing? Surgical, that's a rhetorical question, okay? Surgical failure, complications, we've got to confront failure, learn from mistakes, as I said, and the courage to repeat an operation on the same patient. I know many surgeons who've not gone to see their patients after they've had a flat failure or something like that, and they leave the juniors to go and see them instead of confronting the patient, not confronting the patient, but going to visit the patient and supporting the patient, because the patient, that's when the patient needs them most. So let's talk about the surgeon-patient alliance. So this is one of the most famous of the Saving Faces paintings, and this is a barrister called Henry, who I saw when he was in my first year as a consultant. He'd already had surgery and radiotherapy for an adenoid cystic carcinoma that they hadn't taken out properly when they did a maxillectomy. And within 2 or 3 years, he was back. The surgeon who operated on him had left, and he was operated by 2 or 3 surgeons together because they felt it was such a difficult case. It wasn't really, but anyway. And so I had to do not a radical operation then, but a reasonably radical operation. I went into his intracranial fossa and took all the tumor out that was at the base of the skull. And he, over the course of about 14 years or 15 years, he died ultimately of secondaries in his lung from the adenoid cystic. And he died on a weekend away in his by the seaside when he had pneumonia. So he lived a fruitful life as a medico-legal barrister all that time. So he was a great cricketer, but he stopped playing cricket after I took out his left eye in the second operation I had to do, when I did an intracranial operation with my neurosurgeon. And what happened with him and me was that I would say to him, look, there's nothing, we want to save the sight in your right eye, so we want to operate on the right side. There's nothing in the textbooks to say how to do this. Shall we go ahead? Yeah. So, you know, I mean, together, I put it like as though it's the two of us walking into the valley of fear and death together. So he's one example. This was a very famous actress who had a melanoma that was overlooked, and she had multiple operations by well-known surgeons who were fiddling around. And in the end, I had to take out the eye when she came to see me. And she was referred by Alan Rickman, in fact, because he was a friend of hers. And this is her immediately after her operation and free flap reconstruction. And she had complete orbital exenteration and her maxilla taken out and reconstructed. And then 6 weeks later, she was performing at the Chichester Festival Theatre, and the young woman next to her was also performing, and is her daughter. And so she carried on performing, and she did it. She was in The Seagull, and if you don't know the story of The Seagull, it's about an older woman who is a very well-known actress who has an affair with a younger man, and finally he leaves her for a younger woman. And so that kind of suited the part, really, that she'd had an operation on her eye. Well, nobody knew what the operation was, but anyway. So employment is really important in self-esteem. So we'll come back to that again in another one. So this is another Henry, and this is a psychiatric nurse from Nigeria who was about 25 when he came, and you see the picture on your left, I think it is, if it's the same as mine, with him after he's had his chemotherapy for the multiple recurrences of his osteosarcoma. And it was at that stage, that was in my second year, the operation took 23 hours. I did it with my neurosurgeon, and he left hospital 2 weeks later, and he lived another around 15 years. He became a charge nurse in a hospital psychiatric department in West London. He got married and had Jeremiah, and he had multiple other recurrences. He had another recurrence on the left side, completely separate. But he'd had surgery beforehand. He'd had a maxillectomy in Nigeria beforehand. So, but I mean, for him, he said, look, I've got a job, I've got a master's. I went and did a master's at Brunel University. I've got a boy, I've married, I've had a happy life. I feel fulfilled. So, you know, when I started, I wanted to cure everybody. Now I don't necessarily, I don't feel like God. That's what I mean. I'm a demigod. And so I realized that I can't cure everybody, but if we can keep people alive and they have a good quality life, then that's reasonable. So the surgeon needs the patient to have support systems. Employment, family and friends are vital in the recovery of the patient. And here's another example. This is another sarcoma. And you can see from the scan that both internal carotids are wrapped in the tumor. So we're never going to be able to take the tumor out. She'd had chemotherapy, but hadn't been able to deal with it. And what we did there was, we're never going to cure her. She had a lot of pain, a lot of symptoms from it. And so all we did was a minimal operation, just so she kept her face, and she was in and out of hospital really quickly, and she died 18 months later, but she was free of pain. So the point is, but she had her husband behind her. I know his eyes look as though they're closed, but he was awake while I was talking to her. So anyway, so he did support her. So sometimes the surgeon or the doctor acts as an advocate for the patient. You know, we have to write letters in support of them if they're having difficulties. We should be honest and humble, and we should concentrate on post-operative support as well as pre-operative preparation. Pre-operative preparation is like the man who coughs in a lift in China, and we then get a SARS outbreak, or we get a COVID outbreak. It's a small thing, but you know, you forget to take the aspirin from the patient and say you've got to have 2 weeks off aspirin, and then they have a bleed afterwards, and they get a hematoma, and they get infection, and then they get DVT because they've been in hospital so long, and so on. So, you know, it's very important that the preoperative preparation is good as well as everything else. And it's great that we have understanding and forgiveness together, that the patient forgives me when I'm not doing well, and understands me, and I understand the patient who's angry with me because I haven't operated on them. So, and patients always want more. So here's a woman who has had a salivary gland malignancy, and it was very important to get it out. So I split her jaw, and you can see that that's her lower jaw on the right, which has been split here and moved up, and that's the lingual nerve, and that's the tumor, which is a malignant tumor. And those are slings around the carotid and jugular vein, so that we can lift that out and clear without trying to do it from an open mouth, and either not take out all the tumor and things. And she's alive and well many years later, but of course she's concerned about this. And so they're very interested in how they're going to look afterwards. This is a footballer a footballer playing for West Ham. And West Ham are in the relegation zone, and they're playing against Manchester United. And the reason he's on the front cover of the newspaper, The Times, is because he scored a headed goal with the, he'd had a broken cheekbone. This is years ago, broken cheekbone. We crafted it, as in the old days, you had to take a moulage of the patient and then cast it in acrylic. We don't have to do that anymore with 3D printing. And he, I was very proud that he scored a headed goal about 3 or 4 days after he'd had his operation. And he saved West Ham from relegation. This woman has had all of the right mandible removed. Right, that's the back of the maxilla, and that's the infratemporal fossa going up to the skull base. And you can see the jugular vein in the neck. She's not satisfied with how she looks. She says, I want to go kayaking and I want to climb mountains, which she did. So, you know, the patients want more. So here's this young woman who I think looks absolutely beautiful. And she's had a left hemimandibulectomy for an amyloblastoma. And she's concerned about the scar. And why shouldn't she be concerned about the scar, you know? But it's small beer compared to what she would have looked like in 1973 after having had the thing taken out. So now I want to move on to the next thing, which is the future of surgery. And so let's talk about the National Facial and Oculoplastic Research Centre. So when you think about surgical research, you don't have to think about, I've put the treatment protocol in very, very small print, because the treatment protocol is the most difficult to get surgeons to participate in. So you can do epidemiology and etiology, prevention, psychology pre and post, investigations, pre-treatment planning, and afterwards you can do all these things, because the face is a very powerful area. So there's a mass of research that we can do. It's like a gold mine waiting to be plumbed, especially when you think of the face and it's the unique concerns about it. So it's not just fear of the disease's effects, but also the fear of the treatment effects. So I wasn't worried about what my knee looked like when I had a knee replacement. But patients do say, will I speak? Will I be disfigured? All these things. Will my friends recognize me? Will I keep my job? Will I keep my partner? All these things are concerns. So I want to talk about corrective jaw surgery, orthognathic surgery now, and what we did with that. So the face is about appearance and identity in the social aspects. I haven't talked about the life and death aspects, but the social aspects: expression, speaking, eating, peer assessment, emotional and financial functionality, because you know, people can get very disturbed after facial surgery, they even commit suicide after facial surgery, and the financial functionality may improve or not improve. So this is another painting from the Saving Faces exhibition, and I'm very happy if anybody wants to host it in Africa. I'd be thrilled. It's been in Europe, it's been in America, and it's not been to Africa. It hasn't been to South America, and it hasn't been to Asia. So, but it's been on the front cover of the South China Morning Post, words on it. So this young woman said that her face changed from the rest of her family when she was 17 or 18, and that her nose moved over to the left, that her jaw moved over to the right, and that she was sunken back and she didn't look like her family. So we operated on her, and there she is, transformed. And she is happier, as you can see. So here's Sue, who was a nurse in my theatre, and she was about 28. And when one day she said to me, do you think you could operate on my face? And she'd apparently seen somebody when she was 18, but hadn't had the confidence. But having been in my theatre, she felt confident for me to operate on her. So we did that, and then there she is, and she says in her story, she says, people used to say to me, because of the way my face looked, that I was miserable, and I wasn't miserable at all, and I was very happy, but everybody said, why are you so miserable? And she said, now my face matches my personality. So, so we did some research to confirm these anecdotes that patients were telling us, their experience of underestimation. And so what we did was, we took photographs of patients who'd had treatment before and after their treatment. And we also mixed in some patients who were race and age matched, and they were what we would call normal in terms of appearance. They have a skeletal 1 relationship as opposed to a skeletal 2 or skeletal 3 relationship. So we went into schools and into hospitals, and we asked teenagers, 16, people of the same age, their attitudes to these people's faces. Now, they didn't know that 16 of the patients had their photographs taken pre-op and post-op, so they're the same people. They didn't know that. So we're looking at 16 normals and 16 ones who had treatment, and they were asked to look at their attractiveness. Well, that's straightforward, but they were also asked to look at honesty and friendliness and violence and intelligence and promiscuity. So here were the subjects, the teenage observers, 130 of them, 17 to 19 years old. And what did they find? They found that the attractiveness rose after the surgery, but they also said the honesty rose, and the friendliness rose, and the violence fell, and the intelligence rose, especially with people, type 2 female, which is what you might call a chinless wonder, somebody with a jaw pulled back. So promiscuity remained unchanged. So they were right when they said that they were in school, their teachers and their their peers, always underestimated them. They thought they were less intelligent. They thought they were less friendly. They didn't have the same number of friends. You know, it was very unusual. So judgments of our ability and behavior are made on our appearance. Negative judgments blight opportunities because the teachers didn't feel that they were up to scratch, that they weren't good enough. Orthognathic surgery releases carefully selected people from chains imposed by their face. So they blossomed to full intellectual, emotional, and financial potential. So now we went back to the patients, and we went to 1 Swedish and 31 UK hospitals, asked their patients. We asked all our hospitals to do this study. So we had a questionnaire that we wanted to give to post-operative patients more than 5 years out after their operation. So 1 Swedish and 3 UK, 31 asked their patients. The patients completed the questionnaire anonymously and analysis. So it was 1,800 patients. Mean age was, as you can see, but there was a range up to 57. Some 57-year-olds wanted their face changed. The problems were, so these are all the problems that they mentioned. So the face was mentioned in 72% of patients, and the teeth in 78%. Lack of self-confidence, low self-esteem, eating problems, speech problems, anxiety and depression, relationship problems. But they were asked to say what the most important was, and the most important was their facial appearance, secondly, their teeth, thirdly, eating problems, and very low down the list was speech problems, relationship problems, and so on. But when they had the results, now let me try and, not satisfied with their teeth, they said 2.4% said that they weren't satisfied with their teeth. Their self-confidence improved, 87% of them said that. Their self-esteem improved, 78%. Less anxiety and depression, eating socially improved, making friends was easier, more energy. And so we generated results that showed that very few people said treatment did not improve the main problem, 1.4%. Improved a lot, 85%. They did have numbness or tingling of their lower lip afterwards, which was a shock to people, the surgeons, that 54% reported some numbness or tingling, but it didn't bother them. And only 2.5% wouldn't recommend it to another patient. So what we found was that it was just confirmed. So it was research. It was a service evaluation, if you like. We researched what the impact of this surgery was, especially it was under threat on the NHS. So facial surgery always affects social performance. It may affect it adversely. The surgeon or the patient must have the same goal. If you don't have the same goal, the patient will expect something that you're not able to give, especially as this is a face-changing operation. The patient-surgeon partnership yields success, not failure, unless you don't cherish it. Research is incredibly important to confirm anecdotes and, in this case, protect practice. So we could summarize that orthodontic surgery does improve physical, emotional, social, and financial performance. So people are paying. So if the government is paying for this, and if somebody stops being a mechanic and runs a successful garage business and is paying more tax, that amply pays back the cost of the operation. I have to say, I'm surprised to say that people don't like surgery or scars. So let's think about other things that we can do. Education, prevention, being less invasive, telemedicine, innovation, okay? So prevention. So the things that we should be trying to solve are the infections, malaria, HIV, COVID, tobacco and alcohol in our first world countries has been a scourge in the past. War is a nightmare that is with us. Man's inhumanity to man kind of continues. Climate change and immigration are things that cause problems. So look at this. This is awe and what did George Bush call it? Awe and
shock and awe.
Shock and awe. So it's a great, if you're that far away, and if you're watching on television, it's a fireworks display, but underneath that are thousands of people, and you know, and it's bizarre. It's bizarre. Why do we have war? Why do we have so many dictators who behave badly and rape their population of money and food and things? I don't understand it. I suppose this could double for climate change, but it isn't. It's war as well. So prevention. So we used facial appearance to discourage tobacco use. So we sent surgeons into about 80 schools. Well, sorry, surgeons into 40 schools, and 40 schools didn't have the talk. And it was a 15-minute talk in a school assembly. And what we did was we followed them up at 4 months and 24 months. 79% remember the school talk. 48% of smokers had quit. Mouth cancer knowledge improved, doubled, and 54% had spoken to their families. So this was something that worked. And this was one of the photographs that we showed. And we showed the operation that he had. So this was showed to all years. In fact, what we're finding here is we've got tumor, metastatic tumor in the lymph nodes high up in the back of the nose. So there's the palate has gone, and the jaw has gone, obviously. That's gone completely. And the neck nodes. And we showed that to them in the 15-minute talk. And the talk is like this. You go in, and not just me, this was lots and lots of surgeons doing it, and it was the most dramatic talk they'd ever given. So you go in, and you're talking to 200 children at a time in a school assembly, and the teachers have gone around, and you can see they've gone to the bad boys and girls and said, I want you to keep your mouth shut. Don't be cheeky to this person. This doctor's come from the local hospital, and you know, he's a surgeon and he wants to talk to you. And the teachers haven't seen the talk at all. And so you start off, and I like to introduce myself, not let them introduce me. And I say, I'm going to talk to you about smoking and the problem that can be caused by smoking or chewing palm. And so you show them the pictures, and each one is worse than the one before. And so the first one goes up and they go, ah! And it's like a vacuum cleaner sucking you in. There's 200 people take an intake of breath, and then they go, ah! did you see that? And they turn to their friends and say, did you see that? And then you wait for it to die down, and then you put the next one. And then and by the end of the talk, it's bedlam. But it's total bedlam. But it has that impact, you know. So then we did a facial injury survey, and we found out that 125,000 serious injuries every year in the UK were alcohol related amongst 20 to 30-year-olds. So we organised a campaign for that, using the same thing, 15-minute talk. We got them to, beforehand, to talk about whether they'd been shrunk and what harms they'd suffered. So they had property damage, there was noise, these are external harms that didn't harm them, waste, you know, vomiting over the place, fear of the people who see all these people vomiting and lying with their skirts up and all over the place, bodies and costs. And then we did internal harm. And every year in the UK, some young people die of death from vomiting and aspirating their vomit. So it does cause death, and cerebral damage, injuries, robbery, legal work absence, and alcoholism. So problems. So it was 16,000 English school pupils. Half had the talk, half didn't have the talk. 13 and 14-year-olds, 44% binged in the previous 3 months. I wasn't surprised that 25% of the boys fought when they were drunk, but 18% of the girls was a surprise for me. And 6% had sex that they later regretted or with no contraception. Surgeons are great at innovation. That's what happened afterwards. I should tell you what happened afterwards. 2 years afterwards, the thing worked in, you know, the pupils in the intervention schools didn't drink as much, so it had a proper impact. What happened with the smoking campaign, it didn't work on girls as well as it did on boys. It worked very well on boys, but not on girls so much. Surgeons are great at innovation. So I'm keen on cross-disciplinary with bioengineering, psychology, 3D printing, health economics, stem cell and molecular biology and tissue banks. So, but that's all growing out of the clinical work that we're doing. So it's translational because it's in parallel with so all the patients who had, who were in the SEND study had blood and tumor taken for biomarkers for cancer. So here is a patient with widespread premalignancy in the mouth. It doesn't look like cancer, but in fact it is. And the way we found out was with this. So this one is the machine made by the company, which is used for aircraft engines to look for metal fatigue. And I can't remember how I found it. I think I was on a plane and I opened a magazine and found this company's and what they were doing. And so we had it modified by them, and we used that to look at these mouths. So this is normal, no dye in this, and this is looking at normal submucosal plexus of vessels. And then on the left is normal staining of nuclei, which is very, very boring, as you can see. And then this is abnormal on the right, which is cancer. So we can differentiate between the two. And so what we did was we looked at these things, which is these nuclei for roundness, and we looked at this stuff for roundness. And what we found was, when we quantified it, that this is the F circle. So 1% or the figure 1 on the left-hand side of the graph is the most round it can be, and the one on the right is not very close to being round. Then we come to microscopic plumbing, and so here we've got 2 great big slabs of meat ready to be used for reconstruction. one with scapular bone and the other without bone, just with skin and muscle. And that is pedicled on the vessels from the armpit, the subscapular axis, which comes off the axillary artery and vein. This is using modern technology, not quite modern technology. This is 20 years ago. So we made a model of the patient's jaw from a 3D print. We bent a plate that before on the back of the model, and you can see how it fits on the model. And we use that to make sure that we put the new jaw made up of the shoulder blade in the right position. And you can see that the dentist who I worked with, who was one of my former juniors and now has a very good practice in central London, made sure, first of all, he came to theatre. There we are putting the plate in place. We haven't joined the vessels yet because you could see that the muscle looks pale pink. You can see that the thing is going to match. And here you can see a great big hole in the face. That's the tongue. That's the back of the maxilla. That's the jaw, and that's the front of the jaw there. And there's the bone put in to reconstruct the bone. And the other flap is reconstructing the hole. Okay. So this guy said to us, this is him after the operation. And he said to us, look, I've got a sarcoma and you tell me I've got to have chemotherapy for 6 months before I have my operation. So why aren't you doing something about my teeth? You know, why don't you get some, you know? So he was the first person ever in the world to have an operation where not only was the jaw taken out, not only was it reconstructed, but also he had implants put in his bone, his new bone as well as the old bone, and those implants immediately had teeth put on. So he had a denture. So when he woke up in ITU, he didn't say my back hurts or something. He moved his teeth together. He said, my teeth don't meet just right. So I took that as a compliment. Anyway, so he's the first one in the world who had that. And then we had this guy who's a Nigerian banker and handsome man. And this is how he presented to me. Actually, this photograph was from Nigeria and was sent to me to ask whether I could reconstruct him. So he's lost his lower lip, he's lost the front of his tongue, he's lost all his upper teeth and the lower teeth at the front. And he's got, you can see right down at the bottom, you can see he had some shotgun wounds in his arm and in his chest. And he was saved because he had a Mercedes car and they shot through the window, because otherwise I think he would have died. Anyway, so there's you can see this isn't him, but he had this kind of thing done, which is, again, this is rib, this is scapular bone, and that's so that's the subscapular axis coming down as the latissimus dorsi, and then sending branches off to serratus anterior and to those things. Anyway, so we did, so this was only about 12 years ago, I think. And so we did a kind of Heath Robinson thing. Nowadays, they do automatic stuff and planning before the surgery. So we were just planning with a little bit of flexibility. And you could see he did have some teeth left in the upper jaw, but not many, and they were broken. And that's the gap in the front. And we used plasticine to bend the plate around. And that's him. That's the back of his jaw. There's the other side of the jaw. This is us with the plate, which looks completely ridiculous. But in fact, we know it's right because we've done it in the laboratory. And that's him afterwards, not after the first operation. The first operation, he did have the teeth put into the scapular bone at the front, and the implants and the teeth. But what I did was I removed a lot of the skin from his back that I put in here, and I used muscle to reconstruct the lip. And although it ended up looking like the lip, I wanted to take it out so that I could get a better lip here. So he's already had now another old style flap, which is called a carapandage flap, which was for reconstructing lower lips after surgery for skin cancer. So I used that, an old technique, in a second operation to bring that out and take away some of the skin of his back, which doesn't look anything like the skin of the face. So now we're poor at evaluation. I've put my phone away, so I haven't looked at the time. Let me just check. I won't dwell on things. Okay, fine. All right. So we're coming towards the end anyway. We're poor at evaluation. There's the story about the TM joint prosthesis. So in America, a guy called Kent produced a Dacron prosthesis for the jaw joint and wrote about it and got a professorship out of it, and then lectured all over the world, patented it and got lots of money, became very, very rich, but then hadn't done any long-term, small-scale evaluation of it. And sure enough, all of them had to be taken out, thousands and thousands of them, because they had problems because of the reaction of the Dacron in the area. So there are lots of things. Condyle fractures. In my day, as a trainee, we didn't do plating of condylar fractures. We just tied the jaws together for 2 weeks and then let them move, and they had no problem. But some patients did have problems, just a minority. But now everybody's having plating of their condyle fractures, which is costing more money, more morbidity and things. Same with orbit fractures. I was a very radical orbital surgeon and operated on lots of orbital fractures, but only about 50%. Now it's up to about 90% with some people. The elective neck dissection, 40 years of debate over whether to, all around the world, thousands of papers written on it and meta-analyses about what is, whether should we take out the neck nodes or not take out the neck nodes. Psychological impact, we've not evaluated. Cost effectiveness, and we've not evaluated. And when I was traveling to lecture in America, in San Diego, I bought the New York Times, or it was on the plane maybe. And I was going there to lecture about why we should be doing clinical research. And it says, for much of medical practice, we're not sure what really works. Need a research culture promoting healing, okay? And you can read the rest. So I chose that as my slide in my first slide in the talk. Why do we need surgical research? We get relative success. It isn't about failure, it's about relative success. But if I say to you as a patient with cancer, don't worry, you've got a 70% chance of cure with my treatment. And then my son's just shouted from downstairs. I don't know whether you heard it. I don't think he was asking whether you wanted tea. He was asking whether I wanted tea. Anyway, at least my granddaughter hasn't come upstairs and started talking. The thing I was saying was that, but if I said to you 80%, you'd say, well, why didn't you offer me the 80%? You only offered me the 70%. So it is important to find these differences between the two, relatively successful treatments. So this is a slide that I show to people. So this is another patient who has traveled the world and still has a tracheostomy in place because her parents know too much. They've been to Paris to see Tessier's successors and Marshak's successors. They've been to New York to see McCarthy. They've been to Los Angeles to see Kawamoto. They've been everywhere around the world, and everywhere they've had a different answer. So this poor child has a tracheostomy in at the age of 10. This could have been taken out years ago if they had treatment for her, but because they got different answers, they didn't know who to believe. Okay, so surgeons use practicality as an excuse when it's not true. The National Facial and Oral Research Centre absolves them of problems about statistics and things like that. It's philosophical. They're confident and decisive, so no uncertainty, and they believe what they're doing is right. They learn as apprentices to master craftsmen. We're not really. We were barber surgeons at one stage. We still have that kind of touch of lack of intellectual rigor in learning about, whether some of these things are better than ours. And reassurance, because all surgical treatments are relatively successful. So we have to collaborate to get the numbers up. And how do we do that? But there are lots and lots of single-center prospective randomized studies that don't achieve any change because they're just not statistically sound, because they don't have enough patients. And so we distrust other people, and that's why we don't collaborate with them. So the National Facial, Oral and Oculoplastic Research Centre, I've missed out the oculoplastic in this one, is our legacy for the future, and it's the world's first and only facial and oral research centre. So its mission is to improve patient care through research, to develop evidence for best treatment practice. And here it is for you. It's a unique resource, and it is yours to use for you and your patient's benefit. So everybody who's here should be contacting me afterwards to say, how can I do research with you? I've got a few slides on that at the end. The SEND trial you've mentioned already, so I'm not going to talk about that, but it was a nationwide trial with 68 surgeons in 28 hospitals, and it was the first ever nationwide trial in any surgical aspect of head and neck cancer. And what do we find? 30% survival benefit for one treatment. And the relevance was worldwide. Okay, we did a translational study, looking at resource use, in other words, how much it cost, quality of life, complications, and tissue bank. So you've seen the slide already, so I'm not going to dwell on it, but it just reminds you of all the things you can do without even looking at treatment protocol. So we started doing this trial, which is a very difficult trial because it compared a 1.5 hour operation with a 4-hour operation, and one or 2 days in hospital compared with 4 or 5 days in hospital or more. So so we could have tried something much simpler: translational research, psychological, orthognathic surgery, sociological, domestic violence, tissue engineering, scientific materials, tissue bank. So psychology. Here's a picture of two people. Which one do you think has psychological problems? Obviously, you can't. You could do a straw poll. You could say the man or the woman, if you wanted to, and tot it up at the end. But I'll tell you what the answer is. So the young woman was in a car crash, and you can see she's got skin scars all over her face. She had a smashed orbit, smashed maxilla, smashed on the left, smashed lower jaw. And she's a speech and language therapist, and she's happy and fulfilled. The guy on the left, who looks pretty handsome, I think, wanted an operation on his face because he said that the right angle of his jaw sticks out more than the left. And he doesn't go out during the day. He shops at night. He works at night because he's frightened of people seeing him. He doesn't want to be seen. So what happens with our surgery is that we can have unexpected psychological consequences because we're dealing with the face. So psychology is very important. And then we have these intractable problems. So we want to do violence prevention and science to sort out scars. A scar is for life. A scar just happens in a second. It only happens in a second. The slash. This girl, this young woman, that would have taken about, I would say, 2 seconds to do. And that's her for the rest of her life. This guy was a big, hulking guy who said nobody gave him a job because he had this scar and they thought he was violent. And what had happened to him was he was attacked. He's not violent at all, but people make judgments. Rare disease. So this is a young girl who's got a yolk sac tumor, and this is her post chemotherapy. She's blind in the right eye. Her nose is off to the left. She's still got this large tumor mass, and this is her after surgery. Unfortunately, the surgery got out the rest of the tumor out. What helps with the sarcoma is you should never, ever, ever do surgery on the sarcoma first, because you can't tell where it ends. What the chemotherapy does is it sterilizes the margins so that you know, as long as you've got clearance on the margins, the tumor will never come back. And so this is her, she's now 25, I think, and she's a teacher now. Anyway, so with rare disease, we need multi-center collaboration. That's the point. So what I'd like you as 21st century surgeons is to recognize uncertainty, constantly question your teachers and yourselves, seek areas for collaboration with other disciplines for innovation and advance, contribute to the evidence base by putting patients in clinical studies. And the future belongs to you. The future is clinical research, because funders demand evidence to back our expensive treatments. So that's why you need our research centre. What are our resources? We've got ethicists, public health professionals, psychiatrists, patients, Nobel Prize winning geneticists, a sociologist, and a health economist, all on our board helping us. We've got statisticians, epidemiologists, trial methodologists, senior research manager, and study coordinators that will help. So collaborate with other departments, and that's good. You get a multi-center study. Its advantage is attractive to donors, raises profiles, increases the number of potential patients. But then you've got to agree to everybody else doing the same thing and partnering you. So we could have a national collaboration, which is what the National Facial and Jaw Research Centre is. But why not have an international collaboration? And that's what the Royal College of Surgeons of England is doing at the moment. It's doing things to low to middle income countries. And IMAD is aware of the VRIMS, the virtual reality project that's going on out of one of my former trainees, who's now a professor at Brighton University. It's out of there, and it had 13 or 15 surgeons from Rwanda, Kenya, Tanzania, I think, were the three countries. And then it went out to 14,000 people in 16 countries. No, 61 countries. 61 countries, sorry. Large data set. So what we're talking about, large data set with patients treated by the surgeons, statistically satisfactory. And so it kind of reduces the need of the randomized controlled trial. It's translatable to all international settings. But what happens is the surgeons retain ownership of their patient identifiable data with consent to long-term follow-up for their research. They enter each patient's identifiable data onto the REDCap platform, which pseudonymizes it, so that so that national data banks and NFORC, Advanced Clinical Trials Unit, can have the pseudonymized thing. So therefore, we can do aggregate anonymized studies. And we're now getting, because of COVID and other studies, we're getting journals, medical journals, to accept multi-authored papers. With the largest one that we've done so far is 16,000 authors. So every one of those authors gets kudos in their local setting, and you know, they've contributed hugely to changes in work. Okay, the model is data collection, consent to follow up, simplest minimum data sets. Surgeons and the nurses are best data collectors, and this is how you can join. as a society or individual, select which research project, propose new research, register with NFORC, register with a technology partner in your own country, and then we'll get down to the bottom here, which is no cost for data entry. You can retrieve all your data and publish your own data, but also you can be part of the larger group. Advantages to patients are improved evidence-based information, eliminates confusion over which treatment works best, relevance of all findings for patients worldwide, improved knowledge of national performance standards. So there we are, the National Facial and Oral Research Oculoplasty Research Centre. It's our legacy for the future. This is the Alan Rickman Professorship. Do you recognize him at all? Who's watched Die Hard?
Yeah, I've watched that.
Hans Gruber.
Okay.
Okay.
Yeah.
Truly, Madly, Deeply. Robin Hood, Prince of Thieves with Kevin Costner. He was the Sheriff of Nottingham. You know, so there are lots of things he was in, and he's a patron of our charity who died about 4 years ago. And with his widow, we're going to raise funds for an Alan Rickman Professorship in facial oral surgery at the Royal College of Surgeons of England. We're not sure which university it goes to. I don't really care, because I want them to lead the National Research Centre. And I don't care which country the surgeon comes from, as long as they're happy to come to London and work in London, because at the moment, that's where we are. But I'm happy if we get enough money for more than one surgeon, that we would have a network of surgeons around the world who would combine together to do trials. So it's a crowdsourcing campaign, 1 million people we're looking at. All the Harry Potter actors are going to send out things. If anybody wants to start the campaign rolling, I started with putting in money from our Christmas Carol concerts, and we had some legacy money from Alan Rickman when he died in this thing. So if anybody wants to put in £10 or £20 or £30, I'd be very, very happy as a token of thanks for this. All you can do is contact Saving Faces and find out how to do it. And you would be the first people who would be doing it, bearing in mind we're going to 1 million people. So we're going to go to 24,000 schools in the UK, and they're going to have campaigns to see who can raise the most money, and then they'll get to go to events and things like that we'll arrange. Okay, I hope everybody recognises him. He's more handsome than Snape. So that's us. And I've got to show you something else. So this is my colleague, Simon Holmes, who you saw when I was sitting in my garments and things. And he's got an MSc course on craniofacial trauma and reconstruction, which is done online as a master's course. So if any of you want to join that, you can get hold of him through s.holmes@qmul.ac.uk. He hasn't put it down there, but anyway. And I think that is it.